Thank you very much, Professor Colombo, and also to Professor Ramadori and Hepatoma Research for hosting this webinar. It is my duty this afternoon to talk about the evolving landscape of systemic therapy of cholangiocarcinoma, which has certainly changed over the last 10 or so years. And I think all of the exciting developments that you've heard from Dr. Bracconi have really enthused us as oncologists to think about cholangiocarcinoma as really multiple subgroups of patients with molecular drivers for which there are increasing numbers of treatment options available. These are my disclosures. So just to quickly tell you my outline of my presentation, we do have at the moment 4 pillars of treatment for cholangiocarcinoma: surgery, radiotherapy, systemic therapy, which I'll be covering, and that will include the targeted therapies, and immunotherapy. What I've not included here as a pillar, and it probably is a supporting pillar also, are the local regional therapies, and I think that will be the subject of another 20-minute presentation. With respect to chemotherapy, I want to quickly tell you where we're up to in terms of adjuvant treatment, as well as developments in first-line setting and second-line setting. I won't go over the targeted therapies. Dr. Bracconi has covered these very elegantly. But I will focus on immunotherapy initially in MSI high population, as well as unselected all comers, and give you a sense of the volume of studies that's coming through that will hit some of our journals and hopefully will transform our practice to come. So let's start off in the adjuvant setting. There have been some key large randomized controlled trials. Of course, if you look at small phase 2 series, results can always look somewhat promising, but it's difficult to put those into context without a control arm. The first 2 studies were in patients who underwent resection, either with cholangio and gallbladder cancer in the PRODIGE 12 study, who then received GemOx chemotherapy compared to observation alone. And the second study was one specifically in patients with perihilar and extrahepatic cholangiocarcinoma in Japan, where patients were randomized to receive adjuvant gemcitabine or observation, and both of those studies were negative, and I won't dwell on them any further. There are 2 studies that I am going to cover, the BILCAP study as well as the JCOG 1202, or the other name is the ASCOT study, both of which have informed our practice and tell you what's currently happening in terms of the randomized study, which is now maturing. So the BILCAP study was a UK-wide study where patients with resected biliary tract cancer, including gallbladder cancer, were randomized within 16 weeks of surgery to allow adequate recovery to receive either capecitabine oral chemotherapy, and it was 8 3-weekly cycles, or observation. This Kaplan-Meier curves show the recurrence-free survival for these tumors, and you can see that there was an improvement in relapse-free survival with 24.6 months with capecitabine, 17.6 months with observation, with a hazard ratio of 0.76, which was statistically significant. The overall survival was the primary endpoint. You can see on the left, there's the intent to treat population. There was a numerical difference in terms of median overall survival, so 36.4 months with observation up to 51.1 months, although this in fact failed to reach statistical significance with a hazard ratio of 0.81 and a p-value of 0.097. There was a per protocol analysis, but more importantly, there was an a priori defined sensitivity analysis, which adjusted for prognostic factors, including lymph node status, disease grade, and gender. And when that was applied, the hazard ratio was 0.7, with a statistically significant p-value of 0.007. Just remember this hazard ratio of 0.7 because it's very similar to that seen in the ASCOT study at 0.69. So in this study, patients were randomized to observation or S1, which again is an oral fluoropyrimidine, which is commonly used in Japan. It's not widely used in the West because of differential kinetic profile in Japanese and Western patients. Having said that, within the study, you can see that there was an improvement in the 3-year overall survival, 67.6% with surgery alone, 10% greater in patients receiving adjuvant S1. And as I highlighted, this hazard ratio is very similar to that seen with capecitabine, with a one-sided p-value of 0.008. So those are the reported studies. ACTICA-1 is a study which is still ongoing. In fact, is no longer recruiting. It's now recruited a maximum number of patients, 781, and we're now waiting for the data to mature. In this study, patients who were eligible for randomization following surgery were randomized 1-to-1 to receive observation alone versus combination chemotherapy with cisplatin and gemcitabine, which we use for advanced disease. During the conduct of this study, the results of the BILCAP study became available, and in fact, the observation arm was changed to capecitabine, as this was deemed to be a more representative control of current practice. As I say, this study is maturing at the moment, and in terms of events. However, there has been a small study which has already been presented at ASCO last year from South Korea. And this is looking at patients randomized to capecitabine versus cisplatin and gemcitabine, so the same randomization as the ACTICA-1 study, but focusing on patients with extrahepatic cholangiocarcinoma deemed to be at high risk. So these patients had lymph node positive disease. The results of the randomized phase 2 study didn't show a difference between the two groups in terms of disease-free survival. You can see the Kaplan-Meier curve on the bottom left, as well as overall survival on the right, although the data in terms of maturity for overall survival was still somewhat immature. Does this make a difference? I don't think so. I think the ACTICA-1 study has obviously been powered for a comparison between these two arms as a randomized phase 3 study with a much greater number of patients. So I think the results of that still warrant patience to see what the results are once they mature. So I think to summarize the adjuvant setting, capecitabine is the reference regimen, S1 in Japan, in terms of an oral fluoropyrimidine. The use of doublet chemotherapy remains investigational, but I think there are many unanswered questions. You've heard already that we have included different types of biliary tract cancer, intrahepatic, perihilar, extrahepatic, as well as gallbladder cancers in the studies. Within the studies, the subgroups were stratified, so there was a good distribution of the various subgroups in both of the different arms. But what it hasn't stratified for is the molecular subgroups. This is something obviously that's emerging at the moment, and we need to understand what the prognostic significance is of some of these molecular subgroups, but also should we be considering targeted therapies in molecularly selected population in the adjuvant setting? And if so, for how long? The duration of chemotherapy is currently 6 months, but we don't know whether that would be the optimal duration of adjuvant treatment of molecular targeted therapies. Given the advances in immunotherapy, which I will also show you, one of the obvious questions now is whether immunotherapy needs to be introduced into the adjuvant setting. And once again, the question is, what's the duration of treatment and the optimal chemotherapy spine to be used alongside the immunotherapy? Within guidelines, radiotherapy is still recommended with lower levels of evidence, particularly for patients with involved resection margins and possibly lymph node positive disease. However, this has never been confirmed in a prospective randomized phase 3 trial. I think crucially, we know that these are relatively rare cancers, and it is only really through doing international, in fact, global studies that we'll be able to answer these questions much faster, rather than taking 1 decade to answer an individual question. So let's move on to patients with advanced disease. One of the questions in advanced disease, as in other cancers, has been the intensification of first-line chemotherapy. We know that cisplatin gemcitabine chemotherapy is standard of care, but modest in its activity, with overall survival of around a year. In fact, if you limit this to performance status 0 and 1, the median overall survival of cisplatin and gemcitabine is around 13 months. But the response rates are around 25%, and we do need more effective combinations. So one of the first studies to report was this Amebica study, which was a French study from the Prodige group, looking to see whether the combination of FOLFIRINOX, as we're used to using in pancreatic cancer, could improve outcomes compared to cisplatin and gemcitabine chemotherapy. Very straightforward randomization. So patients with advanced biliary tract cancer, good performance status 0 or 1, a 1-to-1 randomization to modified FOLFIRINOX or cisplatin and gemcitabine. This study was in 2 phases. So there was a randomized phase 2 looking at PFS, and if the signal was strong, the study was then going to continue into randomized phase 3 with overall survival as the primary endpoint. You can see here in the Kaplan-Meier curves that there's not much of a difference. Just to draw your attention, the FOLFIRINOX curves are in fact in red, and the study was looking for superiority over the cisplatin and gemcitabine arm. On the basis of the PFS readout, you can see it's unlikely that that superiority was going to be reached, so the study did not proceed beyond the randomized phase 2 setting. This was a positive study. So you heard about S1 being used in Japan as an oral furoperimidine. And so this study, you can see the Kaplan-Meier curve looking at overall survival as the primary endpoint, did show statistically significant improvement in overall survival using the triplet combination chemotherapy, cisplatin, gemcitabine, and S1 compared to cisplatin, gemcitabine alone. The median overall survival wasn't hugely different, but you can see here the hazard ratio was 0.791, so a 19% reduction in risk of death with a statistically significant p-value, which was one-sided. And on the basis of this, the triple combination has now appeared in Japanese guidelines as an option for patients with unresectable biliary tract cancer. One of the regimens that was very exciting was the GAP regimen, gemcitabine, nab-paclitaxel, and cisplatin. This came from the group in Arizona. Dr. Schroff first produced the results of this phase 2 study. This is a single-arm study. There were 60 patients with a primary endpoint of progression-free survival. And you can see here that there is a large number of patients who are responding to treatment. The response rate, in fact, was 45%, with an impressive disease control rate of 84%. They observed a median progression-free survival of 11.8 months and a median overall survival of 19.2 months. And this is really quite provocative in the setting of disease where we normally expect a median survival of around a year. So on the basis of this phase 2 study, they proceeded to the 1815 SWOG study, which was a randomized study and allocated patients 2-to-1 to receive cisplatin, gemcitabine, and nab-paclitaxel versus cisplatin and gemcitabine alone. The target hazard ratio for the study was 0.7, with overall survival as the primary endpoint. And this study was presented earlier this year at ASCO GI, and unfortunately, the study did not meet its primary endpoint. So the triple combination did not improve overall survival compared to cisplatin and gemcitabine. There were a couple of signals that maybe patients with gallbladder cancer may have had more benefit. Also, the response rates were higher, around 31% in patients receiving the triple combination chemotherapy. So the authors suggest that this may be considered for a subgroup of patients where a response rate is needed, for example, in a locally advanced setting, as well as gallbladder cancer. But looking at the population as a whole, the study was negative. You've heard about FOLFOX already in the discussion. So this is now moving into the second line study. So patients have now received first-line treatment with platinum and gemcitabine. And within the ABC06 study, it was a challenging randomization. Patients were randomized to active symptom control, which meant reviewing patients on a 4-weekly basis, actively and very aggressively managing biliary obstruction and sepsis. And over and above that, 50% of the patients received FOLFOX chemotherapy. And just to pick up one of the points earlier on, there was 42% of patients in this arm had intrahepatic cholangiocarcinoma. What this study showed was that although the median overall survival at this point, the curves hadn't really separated particularly, the hazard ratio was 0.69 with a 31% reduction in risk of death, primarily with a difference at 6 and 12 months with a 15% improvement in survival at both of those time points, although we accept that this is a modest improvement in terms of benefit from chemotherapy. Having said that, many clinicians were already using FOLFOX in the second-line setting, and the results of this study allow us both to have a very honest conversation with patients about what we expect to get from treatment, but also it acts as a useful benchmark for other clinical studies going forward. We also have the results of the South Korean NIFTY study, which was asking the question whether nanoliposomal irinotecan and 5-FU was better than 5-FU alone. So this didn't use a control arm of active symptom control. This used a chemotherapy arm. So it's looking at the question of doublet versus 5-FU monotherapy. This showed an improvement in progression-free survival with a hazard ratio of 0.48 and an improvement in overall survival with a hazard ratio of 0.68, which in fact is very similar to the hazard ratio seen within the ABC06 study. And how has this been adopted into guidelines? So these are the NCCN guidelines. FOLFOX is still down as the preferred regimen, and this is probably because of the level of evidence is coming from a randomized phase 3 study as opposed to a randomized phase 2 study, with other options like FOLFIRI, regorafenib, Naliri 5-FU included as alternative treatment regimens. But the guidelines do put a lot of focus on the special circumstances, so targeted therapy, as Dr. Bracconi has covered, NTRK gene fusions, MSI high, TMB high, BRAF V600E, FGFR fusions, IDH1 mutations, HER2 positive, as well as RET gene fusion positive tumors. So I think it is important that although we're talking about chemotherapy, alongside we are testing patients to see whether there's a targetable alteration for which there may be a specific treatment. So just to quickly summarize my chemotherapy in terms of first line, more is not better. Currently, triplets have not been shown to be superior in non-Japanese patients. The GAP regimen may be considered if high response rate is needed, although this may not be widely available because of approvals and funding. In the second line setting, combination is probably better than either 5-FU monotherapy or active symptom control, but we need to be aware of the modest gains, and we need to focus on targeted therapy if that's appropriate. And because of these modest gains and the fact that you can see here that the number of leading cause of deaths includes liver and intrahepatic bile duct cancer is high in both men and women, we need to have more effective rational combinations as a matter of urgency. And I'm just going to finish with immunotherapy. So you briefly heard that this is available for patients with mismatch repair deficient patients. So in the Keynote 158 study, all of the patients treated had non-colorectal cancer. You can see here from the legend that in fact there were a number of different cancers, but it did include patients with cholangiocarcinoma and biliary tract cancer. There were 22 of those patients, and the response rate was just under 41%. And in the patients who got a response, you can see this was durable. So it lasted 2.5 years or 30 months. Overall, the group had a rather low median progression-free survival of 4.2 months, but it is important to note that just under a third of patients were alive at 3 years. This is clearly in a selected patient population with mismatch repair deficiency. So what about an unselected population? So as Professor Colombo mentioned, we've had some new studies which have really changed what we do over the past year. This is the TOPAZ-1 study, which took patients with advanced biliary tract cancer of good performance status, and they were randomized to receive cisplatin and gemcitabine chemotherapy with either durvalumab or placebo. At 6 months or 8 cycles, the chemotherapy was discontinued and patients continued their allocated durvalumab or placebo with overall survival as the primary endpoint. These were the results. You can see here the hazard ratio overall was 0.8, so 20% reduction in risk of death with a statistically significant p-value. But you can see that these curves gradually diverge over time with an improvement of around 6% at 12 months, 10% at 18 months, and 15% at 24 months. And notably, approximately 1 in 4 patients are reaching 2-year survival. The survival data have been updated, and this is the most recent data cut, which has tightened the hazard ratio to 0.76 from 0.8. And once again, you see this gradual divergence of the curves, and the 24-month overall survival is holding at around 1 in 4 patients. This is the exploratory forest plot looking at the subgroups. So you can see that patients benefited regardless of sex, age at randomization, PDL expression, disease status at randomization, the tumor type, performance status, and so on. There has been the question of whether PD-L1 expression will allow us to pre-select patients for immunotherapy. I won't go through the detail of how this was calculated, but you can see that whatever cutoff was used in terms of expression, 1%, 5%, or 10%, in fact, this did not appear to differentiate patients who would and wouldn't respond from immunotherapy. So currently, PD-L1 expression is not useful in the selection of patients for immunotherapy. But what about the molecular subgroups that we've heard of from Dr. Bracconi? In fact, we can see in this exploratory forest plot that all of the subgroups appear to derive benefit. Maybe the one that is on the other side of the line of unity is HER2 amplifications, although the numbers there are very small and the 95% confidence intervals are very wide. And then most recently, last month, Dr. Katie Kelly presented the results of the Keynote 966 study, very similar design to the TOPAZ-1 study. So again, a first-line study, a histologically confirmed advanced biliary tract cancer. The agent was different. So here it was pembrolizumab versus placebo instead of durvalumab versus placebo. The other notable difference is that chemotherapy continued beyond 6 months, except for cisplatin, which was discontinued at 6 months. So patients were allowed to continue gemcitabine. And these are the key results from the study in terms of PFS on the left, an improvement in hazard ratio of 0.86, which was statistically significant, and a median overall survival improvement, hazard ratio of 0.83, with a p-value of 0.034. You can see here that the median overall survival at the bottom is not hugely different between the two arms, but once again, a very consistent message that we're seeing is that about 1 in 4 patients are achieving 2 years using cisplatin and gemcitabine combined with immunotherapy. Again, not to dwell on this, but this is the exploratory forest plot, and it shows that all of the subgroups benefit from the addition of immunotherapy, no obvious outliers in any of those. And just a quick glimpse to the future. This is a couple of years ago since I systematically reviewed all of the studies that were coming through. You can see in terms of phase 3 first line, the 2 highlighted in red are the ones that have now reported. But you can see a large number of phase 2 studies which are really looking at how to harness the immune response in patients with biliary tract cancer, either by adding in additional chemotherapy, dual checkpoint inhibition, inhibition together with local regional therapy, and so on. So my summary for immunotherapy is that I didn't show you the data, but immunotherapy monotherapy in unselected patients is probably not useful, although in monotherapy it may be considered in patients with MSI high, although this accounts for less than 1% of patients. The addition of immunotherapy to cisplatin gemcitabine in an unselected population does reduce the risk of death, modestly improves the median overall survival, but clinically, there is a clinically meaningful 2-year survival of 1 in 4 patients. And I think as a community, we want to try and understand who are these 1 in 4 patients. Going forward, we need to consider what's the role in other settings. What about immunotherapy beyond progression when you change your treatment? What does it mean in the adjuvant setting? What are the other modalities that we should combine in order to best harness the immune response? And just to remind you with this cartoon from the Immunity Journal, that just testing for PD-L1, which is number 7 in the cycle, rather oversimplifies a selection of immunotherapy, which requires the release of cancer cell antigens, which can be done by chemotherapy, radiation therapy, or targeted therapy, and so on. Cancer antigen presentation, priming and activation, infiltration of the T cells into the tumors, and then recognition of cancer cells by T cells. So I think it's likely that we'll need to use a more complex approach to immunotherapy in biliary tract cancer. My final slide, Dr. Bracconi has already shown the ESMO guidelines. The big changes are that adjuvant chemotherapy is no longer a tentative suggestion. It's now established as a standard of care. Immunotherapy has emerged in the first-line setting. Molecular profiling is now introduced as standard, and we have second-line treatment options, including targeted treatment. So very much an evolving field. Thank you for your attention.